In 2016, a family in San Francisco brought their 8-month-old to the emergency room after he rolled off a hotel bed. A nurse checked him, he took a nap, drank a bottle, and the family went home 3 hours later. No surgery, no broken bones, a healthy baby. Then the bill came, almost $19,000. And buried in it was a single-line item, a trauma activation fee, for $15,666. The team that could have saved his life had been switched on the moment he arrived. Nobody told the parents, and that fee is the doorway into one of the most misunderstood machines in American medicine, the trauma center. So what is that fee? A trauma activation fee is a charge for mobilizing the trauma team, the surgeons, nurses, and imaging staff who get paid the instant a serious injury rolls in. It's billed on top of whatever treatment you actually receive, and it's triggered before you're even examined, by the ambulance crew's report or the way you arrive. You never agree to it. Often, you never even learn it happened. To understand why a napping baby generated a $15,000 charge, you have to understand what a trauma center really is. Because the label on that building is one of the most expensive words in medicine, and, to be fair, one of the most valuable. Let's answer it like an operator. What does it actually take for a hospital to call itself a trauma center? And why does that label move millions of dollars? The story runs through a real, measurable survival benefit, an enormous bill just to stay ready, a fee with no rulebook, and a designation that became a business strategy. Two things are true at once here. Trauma centers save lives that would otherwise be lost, and the way they're paid for is a genuine mess. Let's hold both. Start with why the label exists at all, because it is not a marketing gimmick. It's one of the best documented survival benefits in all of medicine. A landmark study in the New England Journal of Medicine followed seriously injured patients and found that 1 year out, those treated at a Level 1 trauma center had about a 25% lower risk of dying than those treated at a hospital without the designation, a relative reduction on top of an already serious baseline. That's not a small effect. For the worst injuries, being routed to a real trauma system measurably improves your odds of surviving. So whatever you come to think about the bills, start here. The thing you're paying for actually works. So what does the label certify? Trauma centers come in levels. A Level 1 is the top tier, an attending surgeon physically inside the building around the clock, ready in minutes, backed by every subspecialty, plus research and training programs. A Level 2 provides the same major acute capabilities, but its surgeon is typically on call under strict response time rules rather than resident in the hospital, and it's excused from the research and teaching mandate. A Level 3 keeps an emergency room and a surgeon on call, stabilizes the patient, and transfers the most complex cases onward. And here's the wrinkle most people miss. The American College of Surgeons, the ACS, verifies that a hospital has the resources, but it's the state that grants the legal designation. Those two don't always agree, which is why the country can't even settle on how many trauma centers it has. Now to the cost, and this is the part that explains the bills. Keeping a Level 1 trauma center ready can run up to $10 million a year, and the American College of Surgeons says most of that is fixed. Fixed means it's spent whether one trauma comes through the doors that day or 50. You're paying a surgeon to be in the hospital overnight for the night nothing happens. You're paying for an operating room held open, a CT scanner on standby, and coolers of blood ready to go, idle most of the time, essential the one moment it isn't. In trauma, the product isn't the treatment. The product is readiness. Think of it like a fire department. A fire station costs about the same whether there are 10 fires this month or none. Because what you're really buying is the guarantee that when the alarm rings, the truck rolls in minutes. Trauma readiness works the same way. One standardized estimate out of Georgia put the annual cost of that readiness at roughly $6.8 million for a Level 1 center and $2.3 million for a Level 2. That money doesn't buy more procedures. It buys the certainty that at 3 in the morning, the surgeon is already there. Which raises the real question, who should pay for standby that mostly sits idle? That's where the trauma activation fee walks in. The trauma activation fee was created to solve a genuine problem. How does a hospital recover the cost of all that standby? In 2002, the National Billing Committee approved a code for it. Medicare added its own version in 2007, tied to being warned by paramedics ahead of time and delivering critical care. The idea was reasonable: let hospitals bill for switching the team on. The problem is what happened next. There is no national standard for how big that fee can be. One center's activation fee might be $1,000, another's, for the identical alert, tens of thousands. And it's hard to even shop for. In the required price transparency data, only about 38% of trauma centers publicly disclose the fee at all. It ended up lesser priced than a guess. Just how wide is the variation? A 2023 study in JAMA Network Open pulled the numbers together. The median top-tier trauma activation fee was around $9,500, but the range ran from about $1,000 to more than $50,000 for the same line item, the same act of paging the team. And most of that spread couldn't be explained by anything clinical. For-profit hospitals tended to charge the most. One trauma researcher at the University of California called it simply the Wild West. Same alarm, wildly different bill, depending mostly on which door the ambulance happened to pick. Here's a different gap, not between two hospitals, but between two kinds of numbers, and it's important to keep them straight. Medicare pays a set, negotiated amount for a trauma activation. In 1 year of data, about $958. The list price some hospitals attached to that same activation reached $50,659. Now those aren't the same kind of figure, so don't just divide one by the other. The first is a net reimbursement, the second a gross list charge, the sticker price. For anyone with insurance, that sticker gets negotiated far down, and Medicare ignores it entirely. But if you're uninsured or out of network, the sticker is exactly what lands on your kitchen table. The real problem isn't a clean markup you can multiply out. It's that the list price bears almost no relationship to what the care is reimbursed at or what it costs to deliver. Once a fee can be 5 figures, the label stops being only a public service and starts being a business. Trauma centers can be very profitable. They pair those activation fees with well-insured injury patients and a lot of downstream surgery. According to reporting by KFF Health News, one large for-profit hospital chain expanded from a single Florida trauma center to 11 in about a decade, and its share of the state's trauma cases climbed from roughly 4% to 24%. Its average activation fee, the reporting found, ran about $26,000 against under $10,000 at other Florida centers. Now, more trauma centers can genuinely mean more access, but it can also mean diluting the caseload and competing for the best insured patients. Both can be true, and here, critics argued, both were. And that tension points to the deepest question in trauma policy. Is more always better? Not necessarily. The number of trauma centers grew sharply over the last decade, which did widen access in a lot of places. But researchers have questioned whether that growth followed need, since some new centers opened where the well-insured patients were, not where the gap was largest. There's also a volume effect. For the most catastrophic injuries, patients tend to do better at busy, high-volume centers than at ones that see trauma rarely. And the access gap is stark. Only about 24% of rural Americans can reach a level 1 or 2 trauma center within 60 minutes, a common access benchmark, against roughly 95% of city dwellers. So the country does have a genuine shortage of trauma care. It's just often in the places a revenue strategy would never build. If you want proof that the readiness is worth something real, look at what happens when it disappears. When a trauma center closes, one study found the odds of dying from injury at the surrounding hospitals rose by about 21%, and by even more in the first couple of years afterward, as the added distance and diverted ambulances took their toll. This is the other side of the ledger, and it matters. The expensive standby we've been describing isn't a luxury. Take it away, and people who would have lived don't. The problem was never that trauma readiness costs money. It's that we've built a chaotic, opaque way of paying for it. So here's the whole thing on one card. 1. The survival benefit is real and measured, roughly a quarter fewer deaths for the badly injured. 2. Keeping that ready costs millions a year, most of it fixed, spent on the nights nothing happens. 3. The fee built to recover that cost has no standard, swinging from $1,000 to over $50,000 for the identical alert. And 4. Because the label can be so profitable, it became something hospitals compete for. Sometimes where the need is, sometimes where the money is. The care is real. The way we price it is the Wild West. So if you take one thing from this, make it this. The trauma center is one of the clearest wins in American medicine and one of its murkiest bills. At the very same time, the next time you read about a shocking activation fee, you'll know it isn't conjured out of nothing. It's a blunt, unregulated tool for recovering the very real cost of keeping a surgeon awake for the worst night of a stranger's life. The care is worth defending, the pricing is worth fixing. Both are true. So the next time you see the words Level 1 Trauma Center lit up on the side of a hospital, you'll know what they promise, a genuine, life-saving guarantee of readiness, and what they can hide, a fee with no rulebook and a business strategy underneath. Next time we follow the money in a different direction. Why the hospital down the road keeps buying up independent doctors' offices and what that quietly does to your bill. For more on how the system really works, visit shanewelter.com. I'll see you in the next one.